Karen has highlighted a number of issues in relation to making technology not just available but usable, and I guess it's something we should probably explore along with some of the issues that Keith raised. But we've also got both Liz and Hans are going to give us a bit of a sound bite about their particular take on today's panel topic, which of course is, can value be achieved in high-tech, high-cost systems, which is a question that we're asking a lot. So we'll get a chance of them to now have their moment to give us some of their key ideas. I've asked them again to try and use the 3 key words just to sort of crystallise their main points, and then we'll have a panel discussion as you've experienced in the last few days for those who've been here. We will also then still offer you the opportunity to ask questions at the end of the panel if you'd like. So in that vein, please write down some things so that when the microphones are available to you at the front here, you can actually then ask that question in a timely fashion, and then we'll get you to morning tea on time. Okay? So to kick off, can I please ask Liz to give us her sound bites? Thanks, Liz.
Morning, everybody. And I'd just like to say thank you to Keith and to Karen for fabulous presentations. And having had my lovely father-in-law who was blind in hospital, I would echo everything Karen says about how hospitals can improve service for people with visual impairment. So I'm Liz Mear. I'm Chief Exec of an organisation called the Innovation Agency, which is in the UK, and it's an academic health science network. And I'm just going to set you a bit of context about what we do and how we're using simple digital technologies in the community to improve quality for residents and consumers, reduce cost, and hopefully keep people away from the doors of hospitals, or if they get into hospital, helping them to manage their conditions. So academic health science networks like the Innovation Agency was set up in 2011 by the Conservative government, and they wrote a policy actually that was quite inspiring called Innovation, Health and Wealth. And that policy set out how we need to encourage innovation in the UK to thrive. We need to use innovation in health and social care to improve health, and we also need to use it. They termed it increasing wealth in the UK, but we would talk about it as increasing economic growth in the vendors who supply innovation into health. So we have 3 purposes: to improve health, to help our system adopt innovation, and also to improve economic growth by growing jobs in the vendors who supply innovation into the health sector. And whilst I've been here over the last 3 days, I've seen some of your fantastic innovation agencies, your Institute for Clinical Excellence. And Keith's outlined how the UK system is fairly fragmented. So we don't do any of that. We sit alongside other agencies who tackle reducing variation, reducing and monitor variation. So you might have heard of Right Care. I know Getting It Right First Time have been out here to talk to you about unwarranted variations. We sit alongside our colleagues in the Collaboration for Applied Health and Research and Care, who work on implementation science. And we also have some fantastic colleagues who work on lean pathways, setting out the changing clinical pathways and working with clinicians to do that. So we work alongside all those parts of the structure. So we're networks within a system. Each academic health science network, like the Innovation Agency, covers a population of between 3 and 5 million people. In my own area in the north of England, that means we have 23 NHS trusts in the region. We have 18 clinical commissioning groups. We work very closely with our 19 universities, and we also support innovation into our 38 local authorities in the one patch. So if you imagine that multiplied by 15. The network of academic health science networks works together. So if an innovation works in one region, it's been trialled, it's been evidence-based, we think it's going to make a difference in terms of quality and value, we share across the 15 and we adopt and spread, or adapt and spread sometimes, the innovation across England. So that's the context of the Innovation Agency. My own context, before I came into this role, I was a hospital chief executive. I was in a hospital that had a hub and spoke model, so worked across a network, so perfect for coming into a network and system role. And I also chaired the clinical research network for the region. So I was involved at the cutting edge of research, research trials and innovation. So that sets the context. So my 3 words, if I can move the... Oh. Yep. So my 3 words for the 5-minute presentation are culture, collaboration and communities. And you'll have heard these words a lot over the last 3 days. And I think sort of thinking about Keith's presentation, the culture bit is about supporting clinicians and staff on the ground to be able to adapt and adopt digital and other innovations. Collaboration is about creating the future, working with partners. And communities is about empowering the person, working with communities to think about what do they need, what do they want, what sort of innovation will they actually use, how is it helpful to them, and letting them drive the agenda around need. So culture. This is one of our clinicians, is a cardiac surgeon, and he's holding up 2 3D printed hearts there. So he actually works in our fully digital children's hospital. We've got a new children's hospital, a bit like you have here, and he's holding up an adult-sized heart and a children's heart that's been 3D printed. So when we think about culture, the Chambers Dictionary defines culture as the attitudes and values that inform a society. And I think working in the health service, that can be redefined into something that's a little bit more practical. And I would say our culture is the way we do things around here when no one is watching. So what is ingrained in us and how do we roll out our practice? So Rob in the picture is one of our innovation scouts, and we recognise that to deploy innovation into organisations, you need some support. You haven't got time, you're limited in being able to make change. So we've trained 70 innovation scouts across the region to support staff in changing the culture. 3D Prints is a good digital example of a company who are based in our children's hospital. They produce 3D prints for surgical teams of the organ that's going to be operated on, and they also do some of the virtual reality where a team can walk through the heart they're going to operate on. They can see what's there, and this reduces anaesthetic time for the patient, and it also supports the team in being able to see what they're going to encounter when they go into surgery. So that's one example of culture. We also run innovation sessions on adoption and spread, quality and safety, to help people to assess their own culture. So collaboration. So the gentleman you'll see here on the screen is Hassan, and Hassan's a fantastic community pharmacist in our area. And we're rolling out a programme across the 15 AHSNs which is called Transferring Care Around Medicines. So you might know that a lot of hospital readmissions are caused by people who can't manage the revised medicine schedule when they come out of hospital. It's about 7% of readmissions is down to that fact. So we've got a computer programme that scans the records of patients who are in hospital, identifies those people who might be at risk of not being able to manage his medicines, and refers them on discharge from hospital to the community pharmacist, who goes to meet with them, sits down with them, talks about the medication, what we need to do to apply the new medication. That's reducing readmissions into hospital, working in collaboration with some of our partners. So communities, how do we work with communities to get them to identify the need and to get them to think about what digital products might be useful for them? So you'll see 2 pictures here. At the top of the slide, the gentleman in the middle is one of our former famous football players who developed an atrial fibrillation that can lead to a devastating stroke. We're trying to prevent these things from happening, so we're rolling out a campaign to detect atrial fibrillation using digital devices. In his hand, he's holding a very simple device called a My Diagnostic, and he's holding onto both ends, and it will tell him if he's got an atrial fibrillation by giving him a tick, if he hasn't, so he's okay, a cross if there's something wrong. So we've got a number of devices like this. I know you use a live core out here, Myocardia, and we're using this device because it's just easy to hold on to. We thought that was a fantastic innovation. We thought we'd be able to identify atrial fibrillations, prevent strokes that can occur as a result of atrial fibrillation. But when people presented at the GPs sometimes didn't know how to prescribe anticoagulation to solve the problem. So we had to work with GPs on education around using digital technologies. You'll see the firefighters at the bottom. Firefighters in the UK, their job is reduced because we don't have chip pan fires anymore. There's not as much smoking, so we don't actually have as many fires. So they've reinvented themselves, and they go into vulnerable people's houses to do safe and well checks. They're rolling out the My Diagnostic as well, and using community actors to help people adopt digital. So all this is really about connecting people. How do we connect people up? How do we think about where the need is? How do we use them to identify what innovations will be useful, digital or otherwise, and how do we keep people away from the door of the hospital, but when they are in hospital, use digital to make sure their stay is good and increases quality and value. Thank you.
Thank you, Liz. Now we'll have a few words from Hans.
Okay. Good morning, ladies and gentlemen. My name is Hans Kedzierski. That's a Polish name for a Dutchman who was working in Pakistan. I'm a hospital CEO for the last 30 years. And since day one, I was told by politicians and insurance companies, you are too expensive. Okay? And since the last 30 years, I'm working on lean projects, business process redesign, clinical pathways. We even tried to work together with our family physicians in the community, which back in the Netherlands 15 years ago failed because they were an unorganized bunch of individuals not willing to share whatever we wanted to share. So when the question was asked to me, can you please in 3 words comment on the question, can value be achieved in high-tech and high-cost systems? My 3 words are, yes, why not? And I will try to explain that. How does this work? Oh, yeah. It depends, of course, on your definitions of value, what exactly is high-tech, and what exactly is high-cost. So when it comes to high cost, most governments would perceive somewhere a limit or a limit that should not be exceeded in terms of the percentage of the gross domestic product or whatever macroeconomic value you perceive. But countries like Norway, Netherlands, Germany, or even US, who have very high, cost, will never be able, even within that enormous amount of money, to manage the ever-increasing demand and the ever-increasing, new technologies that are emerging. So the question will be asked for the next 30 years as well, as I expect. And when we look at the healthcare industry, which we are all part of, it's different from any other industry. It's capital intensive because we have very complex buildings, complex systems, complex machinery, complex equipment. There is research, and every day some new technology comes up. And it's a choice whether you go with it or not. And as a university hospital, you don't have many options. You have to do that because you are teaching, you are into research. There is no other option. Secondly, we are very labor intensive. It's not so that a machine takes away labor from someone. No, it creates more specialties, subspecialties. So we need to train more people to cover always more people on more smaller segments of knowledge. And it's very complex to bring this together. And that takes another intensive increment in labor and headcount. But what makes us very different is that we also are emotion intensive. And we have seen this during these last few days. Just now, the lady was blind, and we had this patient advocate from the USA. So apart from money, labor, we are confronted with great extent of emotions that needs to be managed, and also that will take effort to manage. So do we see here apparently contradicting trends? There is the never-ending desire for new technologies for both business and humanitarian purposes. And there is the never-ending desire for compassion and closeness and access to appropriate care. So we have in our hospital, for example, some instances of how to use artificial intelligence that helps us to manage pediatric ICUs in a better way. And the machine you see on the slide is a MRI linear accelerator, and the cost of it is $10 million. It will increase the accuracy of your radiation oncology treatment, but the cost is very high, and there is no way that we cannot engage in these technologies, and it comes with a price. And the discussion that I was listening to the last few days, okay, engaging communities, spreading out into the more aging communities, it will come with a higher cost. It will not be cheaper. So we need both. There is nothing wrong with high tech, and there is nothing wrong with integration of healthcare systems, and both will be with high cost. So let me skip this. This will take another 5 minutes, and I'm not allowed to do that. So it's a balancing act. It depends on economic conditions, and I can talk a little bit more about developing countries if you like. And it also comes down to political choices. If you don't go for innovation, then for financial reasons or whatever political choices, then don't blame hospitals or anybody else that it doesn't deliver what you want them to deliver. So one cannot blame hospitals to bring high tech, and we cannot blame communities for demanding better primary care. Thank you.
Thank you, Hans. Okay. Let's dive in, starting with you, Keith, about this issue of relevance. One thing I've noticed increasingly in conversations, as well as being reflected in some of the academic literature, is commentary about our capacity to adapt to the changes that are coming, particularly technological. But also, a bit like what Hans was just referencing, the concern that maybe we're focusing a little bit too much and maybe hoping a little bit too much that technology will be the enabler. What I want you to explore, if you could, is this tension that Hans is talking about between the desire for and the expectation of technology being our, inverted commas, saviour, and that we will actually move confidently into that space, and that innovation always means embracing technology. Could you sort of explore that notion of that tension, of this expectation of technology and its actual potential capacity to deliver?
Yeah, look, it's a really good point, isn't it? Because we have throughout history been very innovative in medicine, and it's where we've got to today. And it's just that now we have increasing levels of technology, which is the current focus of innovation, and how we use that technology then to provide care. The issue for me is that if you go back in the past, we've relied on gathering evidence in a very laborious way. Okay, it's been very accurate, it's been very detailed, but it's been very laborious. And sometimes it takes us years to provide the evidence as to whether something's working or not. And then it can take what the average is, 13 years to get it embedded into clinical practice. The challenge, I think, for us now, and really the opportunity in all this, is to be able to embrace innovation. We know it's coming, we're not going to stop it. But what we really need to do is set up the systems whereby we can evaluate the outcomes in a much more real-time sense, so that we can stop if they're not delivering the outcomes and we can move on to something else, or if they are delivering outcomes, we can then spread them so that we get much better benefit in terms of scaling up much more quickly. So that real-time ability to evaluate what we're doing effectively and spread that analysis is going to be absolutely key if we want innovation to really take off. We can't avoid it. It's here, it's now. We've got to find a way of doing it, and to me, that's one of the key ways of doing so.
Okay, so that brings us to the other side of this, Karen, that you referred to, is that this is a personal experience of technology and its uses. And you talked about the ability that an elbow gives you a lot of information. And I'm not sure how many times elbows would come up in a high-tech conversation. So I'm sort of wondering, once again, could you reflect a little bit on this notion of, with this big pressure, technology can be a massively wonderful and empowering thing, but are we a little bit maybe taken by its shininess? And if we are, what are the potential ways that we could navigate that with a little bit more humanity and a little bit more pragmatism, given that your comment about the elbow being powerful?
I think certainly technology has brought some wonderful opportunities as well. and it means thinking about doing things in a different way. So I talked about, the way of guiding and holding on to the elbow, but one of the recent technologies that's out there that in the blind and low vision community that's revolutionised the way you get around is something called IRA, A-I-R-A. So you wear a set of glasses that are quite cheap, they're about $300, and it gives you real-time connection to somebody, generally in the US, but around the world, who can talk to you about moving around your environment. So if you're not sure about where to go, they will tell you where you are, how to find what you want to find. And organisations can subscribe to this, such as if a hospital subscribed to this, then IRA would have a map of the hospital in their database, and it would be linked to your profile. And so you say, yes, I'm going to the hospital today and I need to find this, they'd be able to direct you straight to it. And so what it really has opened up opportunity, but what it also does is it needs to then be accessible to everyone who wants to use it. You probably need you probably need good orientation and mobility skills to get the best out of it. But the other side of all this is the whole human rights thing. Because when you access that technology, they're taking photos of your environment so they can tell you what's going on, but who else is in the photo? Those people don't even know they're in the photo. And often, a lot of this technology is keeping the recordings of the real-time sessions for 18 months. So I think there's lots of opportunity, but we need to understand what the challenges are and be ready to confront those as well. And I think, it's fantastic for people to be as independent and self-sufficient as possible, but connection is critical. And if we lose the connectivity with each other, then there's a whole lot of disadvantage about that, and Liz sort of referred to that also, the notion of community and connection.
It's very interesting. There's so much in that, actually, and one of the things I want to pick up on is the backlash to Google Glasses that came. So the technology was incredibly enabling, but humans didn't like it. And this is perhaps moving to the sort of territory that Liz and Hans, you both walked into. Liz, for you first, we talked about this comment that's come up several times in the last few days. The idea that we want to remove the variation in outcome. Now, understandably, there's a notion of standardisation, that we want everybody to have the equal access to an equally valuable outcome. The question I have is a bit sort of leaning on what Karen's come about variation in the context of an environment such as healthcare. Karen's talking about a piece of technology that takes a map. That map assumes nobody's going to put a trolley in the corridor. Yeah. Nobody's going to leave a door open or closed. That they're not suddenly going to put beds somewhere that they weren't anticipated. So in other words, it assumes a great deal about staticness or standardness. And I'm wondering if you could talk a little bit about that, because some of the issues in this is that what we in the clinical space or the health space value may not be what our patients value. Can you sort of explore that a little bit? And this variation of outcome thing may actually be something we might need to expand a bit.
Yeah, so just thinking about that in maybe a different way, I can give an example of a company we work with who are in the digital health space, who think about this very holistically, about what a person might need, not what we might want to force on them. So they have two products. One's called the House of Memories. It's been downloaded 11,000 times and used by carers to support people who have got dementia. And it's about taking them through a reminiscence journey. So it's a very personal sort of digital experience that helps you to work with someone with dementia, to bring them back to life in a way and to tap into those experiences. And it helps you to support them to personalise the experience. The other product that they have is called Catch, which is an app or a PC platform called Common Approach to Children's Health. And it's a product that is a standard product, but then it's customised for the area. So if you're a new parent or a father or a mother with a new baby and you don't know how to deal with some of the common issues that might occur with the baby, you can go on and look and think, well, is this normal? Would the baby be experiencing it at this stage? But it's also customised for the region you live in, so you can think, actually, that is normal. I don't need to go to A&E, or I don't need to go to my GP. But oh, look, there's a Sure Start centre down the road that I can go and get some support. There's a parent and toddler group where I can go and meet with other people. So I think there's something about customising some of these digital approaches to actually meet the specific individual needs of people, to help them to manage themselves, actually, and not to be presented to health services all the time.
Because that is that challenge, like Keith.
So it's a really interesting analogy you use. So that static map need not be static. So we can RFID tag everything in the hospital, including people, and we can update that map at the speed of light in real time for us. The question is, as we add more and more technology, if we're going to use value as the stake in the ground, when do we reach the tipping point when we go from high value to lower value to low value? And we haven't defined those boundaries, and they're different for different people.
I think that's a relevant comment. What is the ultimate benchmark? What is the ultimate good? And I think that's very dependent on where you are. What is your setting? For example, if I would have to define, okay, what is the golden standard? In a country like Pakistan, I come with a completely different answer than for the UK or whatever other country. And even in my own biotope, the Aga Khan University Hospital, which has also secondary hospitals, and we are creating our own primary healthcare facilities to learn to understand how does this whole value chain work, will have a completely different impact because we control it completely by ourselves. So if you do not control your primary healthcare system by yourself, other dynamics will emerge, different complexities will be. And when politics come in, well, you never know where you end. So there is no answer like, oh, this is the gold standard. There is too much variation. And I think that will never change, and luckily so.
I think it's an interesting question, though, about this issue of variation, which sort of goes to that other question about variation is something we seek to eliminate in science-informed systems, business models, etc. Wondering, though, from the other side, the people who are working in the systems want something they can lean on. The people experiencing the systems want to know there's standards and consistency. However, there's still individuals providing the service and individuals receiving the service. And I'm sort of wondering if you could explore that a little bit, because it's nice and, it's a bit like we sort of gather all this data in particular, but what is the value of that data if it's not relevant to that context that we're actually gathering it into? Because we come up with sort of bigger and bigger global standardisations, but something that Liz alluded to about local. Could you talk to that a bit more, Hans, about how do we actually reconcile? Because you talked about attention, it was more about emotional closeness and technology, but in that same vein, this tension between the standardisation that data assumes it can enable us, but the ability for the standardisation to respond to the needs that actually exist.
Well, let me give a very simple example, and everybody in the audience knows these kind of examples. You talk about a clinical pathway in orthopedic surgery, let's say total knee replacement. And one of the issues is, okay, how do we make sure that there is early rehabilitation, and you define, for example, what is the standard length of stay for the average patient. There will be the second orthopedic surgeon will come and say, listen, yeah, that's fine, but yesterday I had a patient who had da-da-da-da-da-da, and then he says, so we cannot apply this. You say, listen, we talk about 80% of the cases, not 100%, so there must be some variation possible. It depends on how able are you to engage themselves. And I think maybe the issue of clinical outcomes is something that will help us a lot here. Show them what is your clinical outcome as a group, as an individual, and benchmark against whatever international registry you are participating in. And if you are one of the outliers, I hope, I expect, and I want them to think, oh, wait a minute, what's wrong with me? And start learning. Okay, maybe something in my way of doing things has as a consequence that this patient will stay longer in the hospital. And in my system, this means that the patient has to pay much more money because Pakistan doesn't have a national health insurance. There is nothing. People pay out of their pocket. So the impact on the patient is immediately there. So if you change that, if you can improve that, it's immediately benefiting the patient and the community. So what more can I say? And it's a struggle that comes back every day. It's easy to say, oh, let's drive out variation. And the complexity to do that is, even with data, even with artificial intelligence, will never be easy. Because don't forget, the way we train people, we drill them 10 years long to take individual decisions. You meet a patient in the clinic room, you meet a patient in the operating room, you take the decisions, and whatever you learn, it's about you. And if you develop a practice that is different from my colleague, then it will be very hard to engage them in a way that you drive out variation. So if you don't understand that, you will be in conflict with physicians all the time. So you need to understand where they come from and take it from there.
So just following up on that, as we get into more precise medicine, cancer for instance, we're finding that cancers, you can't lump them. In fact, we're finding they're all rare diseases, each and every one of them. One of the things about precision medicine is we're aiming, quite rightly, to be able to very accurately define a patient or a person in terms of their phenotype, what they look like, their genotype, their whole, so that we can very, very precisely apply either diagnostics or treatment paradigms to them. One of the things we haven't done on the other side of the coin is looked at the other part of the equation, which is precisely define the issues in terms of the person who's delivering that care. What are their emotions? What are their social mores? What are their fears? What are their risk appetite, etc., etc. And we can't deliver precision medicine because it's an equation with two sides. We've got to get them both right. And this comes down to Johannes's point about the complexity of what we're dealing with here. But fundamentally, that interaction is where data needs to inform. We've got to give that data relevance and purpose, and if we don't do that, there's no point in collecting it. It's just a bunch of ones and zeros. And it is about informing. My thoughts, my belief is if we can inform those interactions really appropriately, then we'll start to, by default, reduce variation because we'll be providing people with the best evidence each and every time they go to make a decision.
Comments on that?
Maybe one as an anecdotal example. And it happened 15 years ago that in the hospital that I was managing at that time was the largest teaching hospital in the Netherlands, in Alkmaar. And we started publishing clinical performance data. And I recall a meeting with the medical staff, and it was full house because, oh, wait a minute, publishing clinical outcome data internally. And I recall, and I gave a presentation about this is what we want to do, or this is what we will do. And I recall as the day of yesterday that there was a pathologist standing up in the audience and looking at his colleagues and saying, ladies and gentlemen, this is the end of our freedom. So this, about the perception, and it was a struggle of 1 or 2 years to get them used to, discuss data. And that's only 15 years ago. And in my context today in Pakistan, it's even more hard because it touches everything. It touches the academic hierarchy. It touches big egos. It touches power balances. It touches everything that you shouldn't touch, according to them. And you say, yeah, but listen, the only reason why we are doing this is because in the end of the day, we want to improve patient care. It's not to bully you or to harm you. We need to learn. And the only way to do is face the facts, go to the data, and see what we can do, and create a non-punitive environment. I think that's for hospital management or system management or leaders very difficult to create an ambience, to create something that is not punitive, that is stimulating, and that is challenging people. Wow, because that's what you want. But you say, yeah, what is their emotion? And sometimes you need to go back where they're coming from. And actually, that bridge of that gap is hard to bridge.
And this is a very key point, and something that Liz and Karen, you've also referred to, this issue of culture in this space. And culture not just in terms of the traditional definition, which is ethnicity, but our belief systems, the culture of our belief systems, our social systems, our appetite for risk, our comfort with that, our perceptions. And I guess what I'm interested in exploring here, because this seems to me to underlie a lot of this, the conversations we have about a relative degree of certainty that with the right kind of capture, we'll get data that's useful and we'll actually be able to use it. And as Keith has pointed out, there's a lag time, we well-publicised lag time when we actually know from data collection what the evidence is, but we don't use it, of about 13 years. Some papers say longer. So we'll get the data, we get the evidence, and then we'll go, I don't trust it. So what I want to explore is what that is, because it's not like this psychology of data and technology. It was a seminal paper by Neil Adage and colleagues in 2008 related to climate change adaptation, and what they talked about in that paper, what they referred to as the social limits of adaptation. That it wasn't just the presence of our biological, our understandings, our economic capacities and our technological capacities that would determine our ability to adapt. It was going to be things like our values, our perceptions of risk, how we actually understood and interpreted fact, and what our belief systems were. So I sort of want to explore that. Liz, you talked about culture. I think underlying this whole conversation is something that doesn't bubble up to the surface. Can you sort of talk to that point a bit?
Yeah, I mean, I think there's something really important here about clinical leadership, and just using a very practical example. When I went into the hospital I was in as chief executive, we were a failing hospital. We weren't meeting targets, we weren't meeting quality standards for the people who came through our doors. And the clinical leadership was quite negative, actually, and thought we haven't got enough money, we've not got enough resources. So there was a tough conversation to be had about how do we make sure we meet the needs of our consumers, we're not going to get any more money. And the clinical leadership changed, and we got a clinician who really, he led benchmarking outcomes across Europe actually for his specialty, and he stood up there and he said, this is how we can use the data, it's powerful, it helps us as clinicians, it helps the people who come through our doors. Come on team, let's work together, let's be the best that we can be. He arranged conferences of the good and the great to come over to see us, and really drove that quality standard personally, and encouraged colleagues to do that. And we started to look at how we worked with staff to make sure that they were had a good work-life balance, how we could incentivise them to work with consumers, to try new treatments, which the clinicians loved. And the culture really changed because of that one strong clinical leader who then built a strong team around him to raise the game of the hospital.
And Karen, I want to bring you into this as well about this conversation that is now being responded to, or at least initiated. As you made comment in your presentation in relation to culture, is that disability action plans are often done, but they're not implemented. So there's an intention to do better based on needs, but that intention is not actioned. And I'm just sort of, once again, we've got the data, the action plan's been done, but we're not using it. Can you sort of talk to why you think that might be happening? Just to sort of inform us a bit more about what we could potentially do?
Yeah, I think it is, again, about leadership and mindset, and that if you have got leadership that truly is invested in what something like a disability action plan can bring the organisation, then it's that leadership that builds a belief that you actually can change something. So it's that sense of optimism, the sense of that you have all the right information to make choices, and that sort of sense that you can make a change really does permeate throughout an organisation. And that if you can bring people along with you, that also then translates to the consumers that you're serving, because you're giving them opportunities to have information to make decisions in the ways that may be comfortable for them, but at the points where they can make decisions. You know, in a healthcare context, there's a whole lot of places where they're not able to make decisions, where there's a whole lot of other things happening around them. But to give people that a sense of where they can make their own decisions and help them do that and feel an optimism that you can actually make a difference in the outcomes for people, I think is incredibly powerful.
So given that we know this and we've got, once again, a lot of data, why don't we implement when we actually have gathered? Because it's one thing that we've got noble and lofty aims often, but what I'm interested in exploring is, and I mean, how about this broader panel, we've got the data, we know, but why don't we use it?
Well, this comes back to value and outcomes, because we make important what we can measure because we can't measure what's important. And so effectively what we do is we tick a box to say we have an output which is called a disability action plan, and we pat ourselves on the back and say that's great, but we don't measure the outcome of having that plan, i.e. that people with disabilities actually get a really good experience when they come to our hospitals. Now that's moving, and it's a generalisation. But systems, bureaucratic systems in the way we've got them set up, focus on inputs and outputs of things we can measure easily, rather than actually looking at outcomes, and then that's a whole new ball game in terms of how do you define outcomes, and we're struggling as a culture to define what outcomes mean, and how we encompass those, and then how we collect the right data to actually be able to define them and measure them.
And maybe we should be a little bit more pragmatic and practical. I agree with what you're saying. I would like, and this for me is a practical outcome, it's fascinating, big data in radiology. So if you would make my chest X-ray, put it in a database with an accuracy of almost 100%, the machine will tell you this is the diagnosis. And the diagnosis, as for senior residents in radiology or even seasoned radiologists, have an accuracy of 85% or 90%, which is substantially less. So let's make small steps, wherever we can do it there, and don't make it too big. It's good to talk about visions, but tomorrow we are all back in our hospitals and we say, okay, now so you need to make small steps that are convincing, that are, and mind you, what do my radiologists say? Because I say as well, next day we don't need you guys. So they will try to find all they can think of to make sure that there's evidence that they are needed. So listen, guys, your next step will be interventional radiology. So nobody will make you redundant, but help it, use it to define your next step in terms of better quality or better outcomes. Don't resist, but make it digestible. We make it too big and then people get frightened. But if you can demonstrate the benefit, I think it will move.
And I think just to add to that, so if you can take small steps, you can actually fail sometimes, because when we're introducing new things, we are going to fail sometimes. And we're in a culture that doesn't accept failure, you can't talk about it. So as long as it's not life-threatening failure, I think we need to encourage people to take the small steps, and if it doesn't work, fail fast, pivot, move on. And we try to do that in our work, and we actually found out that Sweden have a museum of failure, and we flew the chief exec and all his exhibits over to the UK, and we had so many sign-ups that he was here for a week from healthcare staff at all levels to look at actually things have failed in other sectors. Can we talk about it? Can we uncover it? Not be embarrassed about it. If we're going to try new things, we're going to fail. The key is to fail fast, and let's open up that dialogue so we can make change and learn from our mistakes.
It's a very interesting point, isn't it? Because the whole tech boom is based on you've got to fail big, fail often in order to learn. Yeah. That's the argument of the tech industry, that you have to take a big risk and you often don't come of age as a tech company or an entity until you've actually had a fair amount of failure. So I guess this is a big issue about, it's a cultural issue again, and it's a bit like something, Hans, you were talking about, the pathologists not wanting to feel judged because outcome, if they're at the below several standard deviations on the wrong end of that curve, that's considered failure. So in this case, how do we navigate that one? Because once again, this is a big question.
I don't think we can take big risk. I think we're in an industry where we can't take big risks, but if we're taking the small steps, then if we do fail, we can stop quickly, move on to the next thing that will help the consumer. But I don't think we can actually take big risks. That would be my view on that.
Moving on from the concept of risk, because that's a whole nother rabbit hole we could go down, let's just move into the issue of the money, the cost. Are high-tech systems necessarily high cost? Who wants to play with that question?
Well, I'll start. So technology in and of itself, when you first embrace it, is almost always costly. And it depends on what scale you look at the cost and where you want your outcomes. So if you look at is I'm going to buy one of Hans's MRI machines that's delivering radiotherapy, in and of itself, that's a great cost. If you put 1,000 people through it and they all get a better outcome, and you look at that longitudinally over 10 or 20 years, that might be an extremely useful, productive and efficient way of spending that $10 million in terms of the outcomes. So we've got to get our minds around about what scale are we going to look at and what length of time and whole system outcomes that we need to look at, because there's a societal value to everything we do that we never measure in healthcare. We look at siloed costs in this cost bucket versus that cost bucket versus that cost bucket. We don't bring them together to look at the overall outcome and value.
Hans, do you?
Well, I think health economics, and I agree, it's a one-time cost, and we have to see, okay, what is the benefit? If you can cure people that go back into their economic life, which is not measured in this silo, but is seen in another track. But what I believe personally, and based on my experience, tomorrow there is something else coming up, and we want to have it, especially in university hospitals. You have no option to say no, because you have researchers who are curious, they travel all over the world, say, I want to try this, I want to do that. So there's always a drive to bring in new technologies, and we don't know upfront whether it will be as successful as some technologies that we are working with today. So we have to live with that, and it's a budget decision to say no or yes. And it's a political decision on a national level to say, this is what we want to spend, this is what we can afford, so there are limitations. You can't have all. That's a lesson of life. I think everybody knows that. You cannot have all. There is no guarantee for happiness. So let's accept it. I told you, I'm a pragmatic, practical man, so that's the way life is.
Yeah. In the UK, the government have recognised that sometimes some upfront costs to some of this digital technology, and you'll have to pay something out before you see the benefits. So they've instituted a scheme called the Innovation and Technology Payment, where they will buy certain technologies for 2 years that can be deployed into communities to stop admissions into hospitals. The AF testing devices is one example. The government have put £500,000 into rolling out those products. There's another great digital product called My COPD that helps people with COPD to manage their condition, manage their exacerbations, and they're paying for the lifetime licenses of those products. There's about 12, 13 products in total. We're just assessing for the next set of products. So they're putting the money in for 2 years. Hopefully by the end of the 2 years, we'll be seeing the benefits in the hospital part of the system, so the money can be reallocated to support the continuation of buying those community digital products. So there is a way around it if there's a little bit of money spare for the sort of products I'm talking about.
Karen, how do you see cost in this technology equation? Because often it's sort of like, sorry, we can't afford that, we'd like to, but we can't afford that. How do you want to approach that issue from your perspective?
I think with technology, the cost initially will always be significant, but with scale, things can become more affordable, and it's about how that benefits society. So often if you can deploy technology that will improve from a preventative perspective and prevent people getting into hospital, for example, then you have to look at what part of the health system that it's going to benefit and the health outcomes for the individual that is likely to benefit. But I think it is about making it accessible for people, affordable for people, and usable for people. And if we can do those things, even if it does cost, in the long run, you probably be able to get a benefit that will outweigh the cost.
Just, Keith, your point about we're not measuring some of the benefits.
No, you're right. And I was just sort of sitting here thinking, so I've been a hospital and health service CEO, both in Australia and over in the NHS. And so, I mean, I know if I've only got $20,000 to spend on a car, I'm not going to be able to go out and buy a Ferrari. And if I do, it'll be a heap.
You will be fired.
Yep. But alternatively, I also know that you're put in a position sometimes where someone like Tim Berners-Lee comes up with something that's vague but exciting, and if you don't embrace it, you miss an opportunity. So what's the opportunity cost? And of course, it's an imponderable equation. I mean, there is no answer. It's like quantum mechanics. It doesn't make any sense. And so we've got to juggle, and you've got to look at it in the context of what you're trying to deliver. And that comes back to people's risk appetite, and it comes back to what we're trying to achieve, because we also have a responsibility to make sure that we don't deny society and deny individual patients access to care, to technology that will benefit them. And it's about how do we get that juggle right, how do we balance it right, and who does the balancing? And it's only when you start to get good information and evidence to people that they can start to conceptualise those sorts of balancing of those equations in a sensible way. Otherwise, we're doing it with intuition or a toss of a coin or a finger in the air in the wind, and that's not good enough now. So we've got to make it better and more accurate, but it's never going to be perfect. Sometimes we're going to get it wrong. And we've got to have the courage to fail sometimes, because otherwise we won't push anything. If we don't have the courage to fail, we'll just keep doing what we've always done. You never get into trouble for not doing anything new. I can tell you that. You only ever get into trouble when you try something new and it maybe doesn't work as well.
And that's that courage issue, which has also come up as a thing about our courage to take the risks. I guess it's also the courage to take the conversation into a space which hasn't come up as much as I would have expected in an international context, is that we're talking a lot about in developed world contexts here. And the issue of cost and technology and benefit and accessing and equity in environments where the idea of a car, let alone a Ferrari versus something else, is an interesting context. I sort of just want to extend that conversation into that space. How does this cost technology reality play out in context where you do not have at all?
Well, so I point you to a case in point. Let's look at the NHS, which is one of the most cost-effective or efficient healthcare systems in the world, and the US. And look at the huge difference in GDP spend between the two. It's almost double in the US what it is in the UK, and the outcomes are not as good overall in the US as they are in the UK. So it's not all about money. What it is fundamentally, first and foremost, is, number one, applying the best evidence that we have for the limits that you have, and making sure that you do the things that we know are right, do them right. I mean, we still can't in our society get people to have proper VTE prophylaxis when they come into hospital. We still can't get people who've had heart attacks to have the right medicines. We still can't get people with atrial fibrillation onto proper anticoagulation to avoid them having strokes in our society. Now, there's a whole different set of problems in developing countries, and there's a whole lot of evidence about what they should do about fixing their water and their sanitation and getting primary care right. Forget all the fancy stuff. So it is about contextualising in the society and in the environment that you're working. But what we have to do is, where we know something is the right thing to do, we should absolutely make sure that we do it. If it is evidence-based, let's make sure we apply the evidence and do that consistently, not inconsistently.
But it's difficult. I have on my phone a video recording a debate in the assembly of the province of Sindh in Pakistan, and somebody very passionately accusing a former Minister of Health that he did buy 2 robots, surgical robots, in one government hospital, mentioning that there are so many needs in primary health care in the interior of the province, and how on earth can this happen? Now, you have to ask yourself the question, why would we deny a developing country high-tech solutions? At the same time, why do we spend half of our budget on the army? So it comes back to political choices. And again, there will be limitations, but I would not deny this hospital to have its surgical robot because I want to know, are we able to get this working in a developing country? I believe you should not just talk about water sanitation when it comes to healthcare in developing countries. They deserve world-class healthcare like everybody else. You need to start somewhere. And it can be a robot or it can be whatever. But you cannot stop that. But it's all a matter of political priorities. And look where the money goes. And it's the voter, in the end of the day, the citizen that says, well, I put my money there and don't put it there. So let's face that as well. It's not that we can manage what we think is the gold standard. It's the citizen, the people who go to the ballot and say, this is what I want. And maybe we feel, oh, they are not educated, that's all not relevant. They vote based on whatever emotions or knowledge.
Or data they've received. On that
Well,
note, I want to throw it to the floor, just while we're going, just to continue this conversation. If there's any questions as we sort of come towards the end of this panel, I'm sure you've got some. This topic is actually quite an interesting one, and Hans has taken it into an interesting space in relation to this. Yes?
So thank you very much. Good morning to all of you. So I think this is a great discussion, and I think it is indeed a very interesting talk. But what I haven't heard is something which is called health technology assessment, a science that is pretty much well developed, actually. And I think in countries like UK, you have NICE. In Thailand, you have health information technology assessment program. So I think the whole thing, so where I agree with Hans that a lot of this decision-making is political, but as technicians, as scientists, as people who work in academia and try to bring evidence, I think it is our job to bring evidence to the policymakers. The problem is if you don't bring the evidence, the decision will be entirely political. But if you do bring the evidence, the politician has to think twice before he makes that decision. So I think the role of technology assessment in the health sector is extremely important, and I think many countries, both developed and developing, have to give it some serious thought.
You want me to? Yeah, so from our perspective, any technologies we are rolling out would have had to go through health technology assessment, be NICE approved, we'd want clinical director approval around them. But we sometimes, going back to Keith's point about an opportunity that presents, sometimes we'll have somebody come to us with something that we think actually that's got real potential, and we will support them, maybe take them to the small business research initiative to start to develop that, look at how they get assessment and take them through that pipeline so we get to that point. So we would always be looking to have evidence and approval behind anything we were rolling out.
Yeah, so that's a really good point. And I think there are two dimensions to it, as Liz has referred to. There's no doubt that technologies should be assessed for their efficacy, their safety. And then the question is, what do you do with that assessment in your particular context? If you look at proton beam therapy for cancer, for instance, it's efficacious, it works, costs a shed load of money, but people get great benefit from it. When you contextualise it in the setting of a hospital or a health system, does it then give you value for the money you're going to spend on? And I think that's the unanswered question: is how do we then consider any of those technologies that are proven, that have evidence behind them, in the context of the wider health system? And I don't know anywhere that's really been able to come to grips with that balance between the utility equity argument, what do we try and do for the greater good for all people, versus what do we try and do for the absolute nth degree for an individual. And it depends on the seat you sit in. I used to be a lung transplant specialist and could treat a couple hundred people a year. That's great. But I can tell you, if I was head of WHO, lung transplantation wouldn't be on my radar. So you've got to get that balance right somewhere, and I don't know how we do that.
Well, lung transplantation is on our radar, I must tell you. I'll give you one other example. We invest, and lots of our investments are funded by donations. Because we are a private institution and We want to be independent of the government. So either from our earnings, we reinvest in whatever we think is required, or a donor comes across and says, listen, great institution, here is X million of dollars, but I want you to spend it on this technology in this field because I have a wife or a kid and I want you to do something with it. So now, let's imagine he gives me $80 million and says, build a proton beam thing, which will cost $80 million. He said, fine, here's the money. There are many rich people in the world. So I would build it. And I would try to make it feasible in the Pakistani context. Because I still believe, but I'm not a politician, I'm not a parliamentarian, I'm the CEO of a private institution. And I want my people, my physicians, to participate in research at an equal level as their colleagues in Johns Hopkins or Cleveland Clinic or in the UK or wherever. We might be poor, but we should not be stupid. We are on the helm of new developments as well, and we can benefit and learn from it. I think what is the missing factor is learning. Learn from whatever mistakes you make, learn from data, learn from people who don't use data, and that will make you help understand how reality is actually configured and what could be your next small step. Think big, act small. That's, I think, my vision on that.
We've got one more question before we need to finish up.
Thank you. I love the discussion and I love the fact that you've brought up about the courage to fail, and you've brought up about risk, and you've brought up about learning from the failures. I actually, and also too about implement action plans and not setting them up. It ended up that I've learned the most from the biggest failures, and it ended up my little girl was a modern day medical miracle, and she was diagnosed at 22 weeks in my belly with a heart condition. So Dr. Casey looks like Tom Hanks, sounds like Sean Connery. If it wasn't for him diagnosing my little girl at 22 weeks in my belly, she would have been dead in a day. So the sun rose and the sun set. So this is the NHS and the Royal Victoria Hospital in Belfast. So it ended up that she needed 3 open heart surgeries for the age of 7. So we went to England and we found the best heart surgeon in the world. But it ended up being the biggest disaster because she died of neglect after life-saving heart surgery. And we found it very difficult. We ended up protecting and caring for the Belfast team because we were scared to bring up the failure because we loved them so much. And we called our second little girl Casey after Dr. Casey. Looks like Tom Hanks, sounds like Sean Connery. And we called our third little girl Rosie after the Belfast nurse who rung me the day that Haley died. And I didn't know what to do with the failure, and I found Sorrel King in America, the John Hopkins. Same thing happened to her. She spoke up and said there's something wrong and her baby died. But they had a policy in place, and they called the ward after a little girl and they set up a rapid response team. So I went to the English hospital where my little girl died, and I said, we have a solution. So you talk about the data dump. We are the data dumps, the mothers who keep telling the same story and the same mistakes keep happening. So I found a solution, I'll work with you. Let's set up a rapid response team the family can call. But it ended up, I went as the peaceful warrior. Nobody wants to talk about mistakes, and the mistakes get buried. And then you got to live with them. But my mum couldn't live with the fact that the hospital blamed us for her death because we were over-concerned family, so she killed herself. So you lose your only child, you lose your future, you lose your mum, you lose your past. But we had a fight 2 weeks before she killed herself, so she blamed me for her death. So this is my shame, but it's also out of vulnerability comes power. I love Brené Brown. She's wonderful. She has this TED Talk. You talk about your failures and you embrace them, but you go to entrepreneur conferences and they talk about failures, failures, failures. It's so cool, but you can't talk about failures in the medical world, and it's such a shame because we need a no-fault system. There's no blame, there's no judgment. We're all human. You are doing the hardest job in the world, dealing with the most extreme, experiences. And I want a no-fault system. I actually ended up getting a rapid response team set up in the hospital when my little girl died. I got them to admit neglect 2 weeks before their coronial inquest, but it ended up the peaceful warrior had to turn into the Game of Thrones. And the only people I could get listen to me were the media. So I am your worst living nightmare, but actually if you'd listened to me at the start, I am your biggest cheerleader. And I just want to say thank you to everyone. And I love you for what you're doing. And it's so beautiful to talk about the courage of failure. And I'm going to sit down now before I do the ugly cry. So thank you.
Thank you, and I think we should bring this session to a close on the back of that powerful voice and story.
Absolutely.
Thank you for your time. Thank our panellists, please.